Hello everyone, welcome to GrowMed. This is the part 2 revision video of the gynecology, obs and gynec. In this video, we will be discussing about the important topics very quickly so that whenever you are doing revision, if you watch this video, you will be able to recall the things very easily and it will help you while doing the revision. So let's start the video. Preterm labor means whenever there is labor less than 37 weeks. At less than 37 week, if the labor occurs, then it will be called as a preterm labor. Before discussing about it, let's also discuss an important thing about the dates. When do you call it as term, then when do you call it a preterm, postterm? Okay, so this term pregnancy is again classified into the three categories: the early term, then the full term and the late term based on the weeks. So the early, it will be 37 to 38 weeks, then full term will be 39 to 40 weeks, and the late means 41 weeks up to 42 weeks. Okay, up to the starting of the 42 weeks. So it is classified into the early, then full, then late. So one liners have been asked on these things the date, that they will give a particular week and they will ask you which kind of term it is, whether it is a preterm, postterm, okay, all that. So now in this video we will be discussing about the preterm, because questions are asked mainly on the preterm labor. The questions are asked on its causes, then the management. So the causes of the preterm labor are the infection. So these are the important causes for the preterm labor, the infection. So infections like chorioamnionitis or bacterial infection, urinary tract infection. So these all are a risk factor for the preterm labor. Then the anatomical, this is a very important topic because questions are asked on this. So the anatomical means there are two things which mainly contribute to the anatomical, and that is the cervical incompetence and the uterine anomalies. So the cervical incompetence means the cervix will be short. The normal length of the cervix, it should be between 3.5 to 5 centimeter. Okay, so if it is less than 2.5 centimeter, then it is called as a cervical incompetence and it is a risk factor for the preterm labor. Then the uterine anomalies like the septate uterus or unicornuate uterus. Anomalies like these, they are also a risk factor for the preterm labor. Then the twins, in case of the twins, it will be like the uterus will be over distended and the uterus cannot take that much pressure, or there'll be like one twin pushing the other twin, due to which they can be preterm labor. And likewise the polyhydramnios, because in polyhydramnios also there will be more pressure to the uterus, due to which the uterus cannot balance the things and there can be chances of preterm labor. So these were some important causes of the preterm labor. Now moving on, we will discuss another very important thing, that is the prediction. How can we predict that this pregnancy is going to be a preterm or it can go to the term? So there are various factors which will help us to know, like first of all, as we've discussed here, the cervical length, if it is less than 2.5 centimeter, then we can predict that it can be a preterm labor. Then moving on to the shape of the uterus. So the shape of the uterus will be changing as the labor will come near. So it will be a T shape, then it will become Y shape, then V shape, and then U shape. The shape means the opening, like this is the uterus and this is the cervix. So uterus and this is the cervix. So as you can see here, in the pregnancy, this will be like this, forming a T. Okay, the both will be joined and it will form a T. So whenever there will be opening of this, then it will form a Y like this, then slowly it will form a V, and then when the labor will be occurring near, it will form U. So like this, it will form a U. If you can find these changes in the opening of the cervix, then you can predict that there can be a preterm labor. Then vaginal secretions, which is the fetal fibronectin. If it is present in the vaginal secretions, then there can be a risk of preterm labor. Then another important thing is the history of preterm labor. So if there was a history of the preterm labor in the female, then the next pregnancy also can be a preterm labor. Then moving on to the management, how will you manage if there is preterm labor? So first we will do the fetal lung maturity, assessment of the fetal lung maturity. If the fetal lung is mature, then we will deliver the baby. We will go with the process of the delivery, and if it is not mature, then we will be giving the steroids, dexamethasone and the betamethasone. and after that wait for 24 hours and then again check for the fetal lung maturity. After that we will be doing the delivery. So we will be waiting for 24 to 48 hours, then after that we will do the delivery. Okay, so questions are asked on this dexamethasone and betamethasone, how much dose you will be giving and in what time duration you will be giving. So let's discuss those points also. So for the dexamethasone we will be giving the two doses of 12 mg and we will be giving it 24 hours apart. And for the betamethasone it is 4 doses divided into the 4 doses, 6 mg each and given at the time of 12 hours. So 12 hours apart we will be giving it. Then also there are various drugs used for the preterm labor, to stop this preterm labor, and those drugs are called as the tocolytics. So these will act on the uterus and they will cause relaxation of the uterus. So the drugs which are tocolytics are beta agonist. These drugs, the example are the salbutamol, then terbutaline, and ritodrine. So the famous question asked from these is related to the side effects. So these beta blocker, beta agonist drugs like the ritodrine and salbutamol, they are associated with the pulmonary edema, and this one is asked multiple times. So the question, simple one-liner question it was, the side effect of the ritodrine is pulmonary edema. Okay. Then the other drugs, calcium channel blocker, nifedipine, it is the drug of choice for the preterm labor. Then the other examples are the magnesium sulfate, magnesium SO4, then the prostaglandin inhibitors, then oxytocin antagonist, progesterone, and then nitric oxide. So just you need to remember the two things from this. First the beta blocker and their side effects, and this calcium channel blocker, nifedipine, and MgSO4. Then this was all about the management. How will you manage the patient? So if the question is asked on the prevention, how will you prevent it, then we will be doing it by giving the prophylactic antibiotics if it is infection. Okay, then we will be giving prophylactic progesterone. Then the next important thing which we do for the prevention is the cerclage. So in case of cervical incompetence, we will put the cerclage at more than 12 weeks. So these are a few things which you must remember from the preterm labor. Then moving on, we will discuss about the placenta. So this placenta is also an important topic because frequently questions are asked on it. The image based question are asked on these and the complications related to it. So we will look at all those points from the placenta. So this placenta, it has 2 arteries and 1 vein. The right vein, it is obliterated. So this is also a PYQ asked multiple times, that a placenta consists of which of the following. So they'll be given in the option like 2 artery, 2 vein, 2 vein, 2 artery, something like that, and you need to choose 2 artery and 1 vein. Then it is established at day 21 and completely established. So established means the formation will begin at the day 21 and the placenta will be formed completely by 11th week. Then moving on, this is also a previous year question, that this placenta, it is discoid, it is cronium frondosum, and it is decidual weight. So this is the appearance of the placenta, and the size is, it is 15 to 20 centimeter long in the length, then 2.5 centimeter thick, and the measurement, the weight is 500 gram. Then this is also PYQ, that uteroplacental blood flow is established at term. So this is also a previous year question, that the uteroplacental blood flow at term, how much it is. So it will be 45 to 650 ml per minute. This one is the blood flow through the uterus and the placenta. Then fetal blood flow through the placenta, it will be 400 ml per minute, and likewise the uterine blood flow, it is 800 to 900 ml per minute. So during the pregnancy, the blood flow to the uterus, it will be 800 to 900, then the fetal blood flow through the placenta 400 to 400 ml per minute, and this uteroplacental 450 to 450. So you need to remember these things by heart, these things, because one liner can be asked on this. Then moving on, questions are asked on the signs of separation. So as you can see here, the 3 options are there. So it can be asked like all are the signs of the placenta, except kind of a question can be asked on this. So how will we come to know that the placenta has separated? It will be giving us 3 signs: the lengthening of the cord, then fresh bleeding, the gush of a fresh blood will come out, and the suprapubic bulge. So these 3 things are the signs that the placenta has separated from the uterus. Then moving on, so morbidly adherent placenta. So this is a condition in which the placenta is strongly attached to the uterus and it is not separating, and it occurs due to the absent Nitabush layer. So the absent Nitabush layer will cause this condition, and this is called as the morbidly adherent placenta. So this is also of three types: accreta, increta and percreta. So accreta means it will be strongly adherent to the myometrium. So the fibers, the placenta fibers, these will be accreta means it will be tightly attached to the myometrium. So into the muscle layer, these will be just attached strongly, and if it invades the muscle layer, that is the myometrium, if the placenta goes into the muscle layer, then it is called as the placenta increta and placenta percreta. It will be involving the muscle layer, that is the myometrium, and it will extend till the serosa, so it will be called as the percreta. Then the questions are asked on its separation, the placental separation. So this is the natural thing which will be occurring, and how will they separate naturally? So there are two types: central, which is also called as the Schulz, and the marginal, which is called as the Duncans. So the central separation means this is the placenta, so it will be start from the center, it will start separating, and then the margins are separated in the last. But in marginal, what happens is that the placenta will start separating from the margins, and then the center part will be separated last in the marginal. So this was the difference between the central and the marginal. There are other two methods for the separation of the placenta, which are the Creed's method and Branded and Andrews method. And for the controlled cord traction of the placenta, which is a part of the active labor, which is a part of the third stage of the active labor, controlled cord traction, in that this Brandt and Andrews method is preferred. So let's discuss another important thing, that this morbidly adherent placenta, how will you manage the patient? So we need to do the hysterectomy, and this hysterectomy is called as the obstetric hysterectomy, because due to the obstetric condition we are removing the uterus, and later we will be giving the methotrexate or the actinomycin. Then moving on, we will discuss about the placenta, the types of the placenta, the variations present in it. So as you can see here, the image one, filamentous insertion. This filamentous insertion is associated with the vasa previa. So the marginal filamentous means these blood vessels, the umbilical cord, it will separate before attaching to the placenta. So due to which we can see the vasa previa. Then marginal or battledore, it means there will be marginal insertion. That means the umbilical cord is attached to the placenta at the margin, and this can be detached during delivery. So this is the complication associated with the marginal. Then the succenturate, which is also called as the accessory lobe, as you can see here. So there will be lobe present, and this can cause secondary postpartum hemorrhage. Then circumvallate, so here circumvallate, as you can see here, that there will be double folds of the placenta membrane, and this is associated with the abruption and the IUGR. Then there can be bilobed, this is another variant of the placenta, and this is also associated with the abruption and polyhydramnios. Then circummarginate. So in this circummarginate placenta, there will be an extra layer called as the extracorional placenta, and this is associated with the abruption and the IUGR. So these were the things from the placenta which you must remember, and these are the previous year questions which are asked from this placenta. Then moving on to antepartum hemorrhage. So I have already uploaded a complete video on this, a detailed video on this antepartum hemorrhage. So do watch that video also. Now in this video I will just quickly say what does it mean. So antepartum hemorrhage, if there is bleeding from the genital tract after more than 48 weeks till delivery, then that is called as the antepartum hemorrhage. So the tocolytics, these are contraindicated in case of antepartum hemorrhage. Then this antepartum hemorrhage classified into three types. The first is the abruption, the second is the vasa previa, and the third one placenta previa. So abruption means the placenta will separate by itself. So the placenta is separated, as you can see here in this image, that this is the placenta and this has separated from the uterus, and it will cause bleeding. So it can be of three types. Revealed means the blood will be coming out from the vagina. Concealed means the blood stays in the uterus itself, and bruised means the blood will escape into the other parts of the uterus like the muscle. Then the abruption, it is most common cause of the antepartum hemorrhage, and also the most common cause of the DIC, disseminated intravascular coagulation. This is a PYQ. A simple one-liner was asked that which of the following is the most common cause for the DIC. then this condition is painful, and the best management is the immediate induction of the labor. So if at all a clinical case is given, then they will be describing these things in the question, like painful bleeding, the fetal parts are not palpable, the uterus is tender, and heart rate is absent. So there are two buzzwords present here by which you can come to know that it is the abruption. The first is the tender uterus, and second the painful bleeding. Then for the severity, it will be sheet and page classification. By using this classification, we can come to know how much severe it is. Then moving on to the vasa previa, as we had discussed here, that vasa previa is associated with the filamentous insertion, filamentous placenta. So this is the image of the filamentous placenta asked as an image based question in the past year. Okay, so vasa previa means there will be bleeding, and that bleeding will be from the umbilical cord. That means the bleeding will be of the fetal origin. Then this condition is painless, associated with the filamentous placenta. The best test to detect this is the Doppler done in the third trimester, and this was a PYQ. Then management, cesarean section, and if at all a clinical case is given, then things will be like a painless and fetal heart rate will be absent. Then there will be a test done called as the APT test to distinguish between the fetal blood and the maternal blood. So this was also a PYQ, that which test helps us to distinguish between the maternal and the fetal blood, and the answer is the APT test. Then moving on to the third type, which is the placenta previa. So these are the types of the placenta previa: low-lying, marginal, partial, and complete, and image-based questions are asked on it. This marginal placenta, frequently image is given this image, and questions are asked that which type of placenta it is. So it will be marginal placenta. Then moving on, the management. So if it is low lying, then we will give a trial of the vaginal delivery. If vaginal delivery occurs, then well and good. If not, then we will do cesarean section. And if it is complete previa, then we will be going directly with the cesarean section. So this condition is also a painless condition, and gold standard investigation is the USG. Then about the management. If this bleeding occurs at term and presents with or without bleeding, then we will be doing cesarean section. If it is 32 weeks and presents with bleed, then we will be doing the McAfee-Johnson regimen. So this is also a previous year question, and in this regimen we do resuscitation, rest, and give steroids. And if a clinical case is asked, then things will be described like it is painless and the fetal heart rate will be present. So there will be no harm to the fetus, because this bleeding, it is occurring from the maternal side. As you can see here in this image that in this vasa previa, that this fetal heart rate was absent because the bleeding, it was from the fetus. So the fetus was affected in this vasa previa, but whereas in the placenta previa, the fetus will not be affected. So this is a differentiating factor between the previa, between the vasa and the placenta previa. Okay, then moving on to the postpartum hemorrhage. So hemorrhage means this is also the bleeding, but postpartum means it is after the delivery. Okay, then so when do we call it as a postpartum hemorrhage? So there are two conditions when we can call it as a hemorrhage. If there is blood loss more than 500 ml in normal delivery, then it is called as the hemorrhage, and if more than 1000 ml in cesarean section, then it is called as the hemorrhage. So this is a PYQ. So it is the most common cause of maternal mortality, asked as a one-liner in the previous year. This postpartum hemorrhage classified into the two types, primary and the secondary. So primary means the bleeding will be occurring within 24 hours, and if the bleeding occurs after the 24 hours but till 12 weeks, then it is called as the secondary PPH. So the most common cause of the secondary is the retained bits, that means the placenta. So the placenta bits will be retained in the uterus, and management is curettage by removing the bits with a curate, and that is called as the curettage. So questions are also asked on this causes, the complication of the curettage, and it is the Asherman syndrome. That means while doing a curate, overzealous curettage, that is continuous scraping the endometrium, so that the scraping the endometrium so much that the whole endometrium will be removed, and the curettage will reach even the myometrium. Okay, and when it will reach the myometrium, then there will be formation of the scars, so due to which there will be absence of menstruation, which is called as the Asherman syndrome. Okay, so this is also a PYQ. Then moving on, we will discuss about the causes of the postpartum hemorrhage. So the poor tone of the uterus, then any trauma to the uterus, thrombin deficiency, and the retained bits as we have discussed here, the placenta. Okay, so there are Also, a few things which we can do for prevention of the postpartum hemorrhage, and they are the oxytocin, which is given in 5 to 10 international units IM, then controlled contraction and massage of the uterus. Then the treatment. So for the treatment, we will be using the oxytocin, which is the drug of choice for this condition, and we will be using it in 10 to 20 international units. We will be giving it IV. Okay, so for the prevention and the treatment, the dose of the oxytocin is different, and even the route of administration. Okay, then methyl ergometrine, carboprost, misoprostol, factor 4, then uterine artery embolization, then sutures, and the last treatment left is the hysterectomy. If at all the bleeding is not controlled by following these things, we have done all these things but still the bleeding is not controlled, then we will be doing hysterectomy. So it is the last treatment modality. So questions are asked on this postpartum hemorrhage, that a clinical case that you had given the oxytocin, then after that you also given methyl ergometrine, then you also applied the uterine artery embolization. So what will be the next step you will be doing? So it will be like either applying the sutures or we will be doing the hysterectomy, so whichever will be given in the option. So these were the things from the postpartum hemorrhage which you must remember. So if at all a clinical case is given, then the things will be described, like after the delivery there is bleeding and there is poor tone of the uterus, then what is your next step of management? So it will be giving oxytocin 10 to 20 international units. So this was a quick revision video of the gynecology obstetrics. Hope this video will help you all in your revision. Stay tuned for more videos related to the FMGE. Thank you so much for watching this video. Like the video, share it with your friends, and if you're new to GrowMed, subscribe to GrowMed. Thank you so much. Bye bye.